Hello everyone, this is Whittle. I'd like to share with you our step-by-step approach for a minimum invasive esophagectomy. Patient on the left decubitus with the right side up and double lumen intubation. As you can see, the right lung is isolated, a bit emphysematous, so it's taken a while to drop. This is a 55-year-old heavy smoker, as you can see, who was complaining of long-term reflux ended by dysphagia. His upper GI endoscopy showed lower esophageal adenocarcinoma, and after an MDT meeting, we decided for a neoadjuvant chemo, then take him to surgery for a 3-field esophagectomy. Our approach starts with the uniportal thoracoscopy, mobilization of the whole esophagus. Because, like I mentioned, because of the lung takes a while to drop, we just start wherever we see. We usually start from the lower esophagus and come up, but since we exposed the esophagus below esophagus, we start a dissection from there. We incise the pleura posterior anteriorly and meet at the lower esophagus, at lower esophagus, and then we'll take down the esophagus. Once we incise above and below the esophagus, we loop it and transect it with a echelon vascular stapler. So we continue our dissection to expose the whole esophagus from cranial to caudal. Then we'll start looping the esophagus. We like to go as high as possible, just close or below the subclavian artery. Dissection here is a bit tedious because of the surrounding vital structure. You have the trachea anterior and with both vagi. So we usually leave it till the end after we mobilize the esophagus and loop it. So we're dissecting between the esophagus and thoracic duct and esophagus, trying to expose the thoracic descending aorta. You can appreciate the multiple perforators coming from the aorta on the esophageal wall. Care is taken to avulse these. Otherwise, it's a easy, straightforward dissection until you expose the aorta. Once we see the aorta, and this is our plane of dissection, we mobilize the esophagus, like I mentioned, from posterior mediastinum, and now we just finalize the complete mobilization of the aorta. Just freeing the esophagus from the left atrium, as you can see, and connecting the dots. Once we mobilize the esophagus and looping it with the right angle, we use a ribbon gauze or a Penrose to secure the loop, and this will help in further picking up the esophagus from its bed and can continue the dissection of the flimsy surrounding. Continue our dissection now cranially after we mobilize the esophagus distally. You can appreciate the visualization of the subcarinal lymph nodes, and we'll just leave it for a while there. Some would dissect it with the esophagus, but would you like to continue the full mobilization before mediastinal lymph node dissection? Now just mobilizing the esophagus from the left main bronchus, posterior wall and membranous wall, and continue the rest of the dissection cranial. We don't see the continuation of the thoracic duct, so probably was injured in this dissection. Well, so we'll go on at the end to clip it, and this will usually suffice. The clipping will be more distal from the area. Now we mobilize the esophagus from the left main bronchus. You can see the bulge of the LMB. This is a left-sided double lumen, and this can help us in showing where is where. Now the dissection is freed up to the cervical part. Care to be taken and not to injure any vagi in this area, because I don't see the trachea at this time, but it's more interior. Now, after we're happy about the full mobilization of the esophagus, attention is now directed to mobilizing, dissecting, and delivering the subcarinal lymph nodes. You can see it just going underneath the right main bronchus, and we'll just dissect the whole thing as part of the routine. Now, just checking for hemostasis in that area and making sure lymph nodes are removed. Our final step is to mass closure of the thoracic duct, double checking that a missed injury was not apparent. So, two application of a hemlock will suffice to controlling any proximal injury. The whole area was checked for hemostasis and secured, and this will end the first part of the procedure by mobilizing the whole esophagus. And patient now will be shifted in supine position. With the neck and chest and upper abdomen down to the suprapubic area. All this will be protectory for the next step of the procedure. Our chest tube position is usually in the posterior area, just at the thoracic duct, and the lung is inflated under direct vision, and the wound is closed. Our uniportal approach is enough dissection and mobilization, and we've had excellent post-op pain control after that. Our standard for our laparoscopic part is 5 ports in total, a 5mm suprapubic for the camera, and 3 5mm ports, one in the subxiphoid for a liver retraction, and 2 working ports on the left side of the abdomen, as well a 12mm port on the right side of the abdomen for the stapling and creation of the gastric conduit. So we're doing a gastric conduit and dissection of the proximal stomach. Of course, the artery in supply will be the right gastric plug. So the gastrocolic omentum is incised at least 2 to 3 centimeters away from the greater curve. We can appreciate the pulsation of the gastric colic in the beginning. So the dissection is continued up to the short gastric. As you can see, we're not grasping the omentum by any means. Most of the traction is via the posterior or anterior gastric walls, and avoiding even the slightest application of pressure on the greater curve. The preoperative CT showed matted lymph nodes along the lesser curve and along the left gastric. This will be taken down later on, but you can appreciate some adhesions on the posterior gastric wall, and flimsy, but necessary to taken down to expose the area. We're far away from the takeoff of the right epilogue. Also the GTA. Now we're just mobilizing the rest of the gastrocolic omentum, and later on we'll be doing a cohortization of the duodenum. Now we stumble upon a big lymph node at station 8 over the hepatic artery, and this will be dissected later on and mobilized with the specimen. Trying to figure out the starting point and the end of this big lymph node sitting in this area, and as you can see, it's sitting on the hepatic artery. So, in preparation of our gastrectomy, we're mobilizing all the lymphovascular attachment on the lesser curve, and our next step now is doing a pyloroplasty for easy drainage of the conduit. Now, our pyloroplasty is done in the usual fashion of any enterotomy, a McCulloch Culkin approach. A horizontal incision and a vertical closure. We used a running V-lock suture. Now we're ready for our tubularization. We use reinforced staplers to conduct our tubularization. We start as close to the pylorus as possible and tubularize around 2 to 3 centimeter of new esophagus. Multiple firing were used to complete the new gastric conduit along the lesser curve. I call this a reverse sleeve gastrectomy. You want to be away from the angle of hits in both procedures, one for oncological resection and one for to avoid ischemia. We use probably 6 reloads to finalize the neoesophagus tube. As you can see, as we were going more and more cranial, we're very happy about the vascularization of the conduit. Now we're doing our lymphadenectomy, and like every procedure, we're dissecting on the superior part of the pancreas and mobilizing all lymph nodes in that area. As you can see, the tumor was abutting in the pancreas on the posterior wall of the cardia, with the matted lymph nodes near the left gastric. Once we located the common hepatic artery, we continue dissection and mobilization of this big lymph node sitting on it. Care is taken not to be close to the GDA from the takeoff, but the flimsy lesion made it easy to visualize and avoid injuries. Now we're dissecting the hepatic artery coming back to the celiac, just to find out where is the takeoff of the left gastric. It's embedded between this lymph node, and slight and dissection piecemeal will visualize the left gastric at the end. So, time-consuming slight dissection in this area. Visualize the takeoff of the left gastric artery. We'll just take out all the lymphatic structures next to the artery and visualize its takeoff and mobilization of all the lymphovascular structures in that area. I like to completely skeletonize the left gastric before ligation, and so I can mobilize all the lymphatic and lymph nodes sitting on the artery and sweep them with the specimen. So there was good planes between the tumor and pancreas. Dissection continued in that area gently, and we know the splenic is embedded behind this pancreas, but we have good planes between the two organs. And accessory hepatic branch was controlled as well, and mobilization of the whole tumor was done. Now we're just dissecting the hiatus so we can mobilize the whole tumor from the area of the GI junction. We always keep this step at the end. We don't want to dissect the hiatus early. We'll lose all the laparoscopic gas. And as you can see later on, once we open the pleura, we'll lose a tremendous amount of laparoscopic gas into the thoracic part. At that time, the chest tube was clamped so to avoid leakage of all the laparoscopic air down up in the chest and through the chest tube. We like to also dissect all around with an in-block dissection. If we needed to shave off both crura, we would do that to get a large margin of resection and avoid positive margins. So, like I mentioned, I take a wide margin at this area, even if I need to open the contralateral pleura and mobilize as much of the area here with all the lymph nodes and adhesions. Once that's done, we're ready for our gastric pull-up. So we start our dissection in the neck first. Already, like I mentioned, the whole neck, chest, and abdomen was prepped and draped. So a left oblique incision along the anterior border of the sternomastoid was done. Dissection down to the esophagus and looping the esophagus was done. As you can see, we're just mobilizing any adhesions in the cervical part of the esophagus before pulling the specimen into the abdomen. There's a lot of ways to do a stomach pull-up. We elected to do this, and I'll tell you why at the end. So a stapler was used to transect both ends. Our next step is doing a finesteel incision in the lower abdomen. This will be used for a 15 millimeter port to introduce in that area and deliver the whole specimen from there. It's a less of a pain post-op than a midline laparotomy, and it's also cosmetic in nature. You can see I'm dissecting along the anterior abdominal with the cameraman showing me where I'm going. You want to go between the two medial umbilical ligaments. And under vaginal, we'll insert a 15 millimeter endo catch that will just go up as high as possible to deliver the specimen. So once that's done, the whole specimen is delivered into the abdomen. Now, based on the size of the tumor or the matted lymph nodes, if it was a very small, I would elect to deliver it through the neck without transecting the conduit from the tumor. But in this situation, we have a very big tumor in the lower esophagus with matted lymph nodes, so I decided to deliver it through the abdomen. The whole specimen is put in an endo catch under vision and delivered through the finesteel incision without doing a laparotomy or delivery from the neck. It adds only a few minutes, but the pain is acceptable without fear of severe pain or post-op or incisional hernia. Now, in order to deliver the conduit through the neck, I insert a chest tube in the neck, and it comes easily downwards along the spine into the hiatus, and I'll suture the tip of the chest tube to the tip of the conduit and pull up to the neck. And like I mentioned, the conduit is excellent vascularized, and you can see no evidence of ischemia. Now we suture both ends and pull under direct vision and deliver through the neck. And as you can see, as we pulled on the whole new esophagus, Our pylorus is just where it's supposed to be. The tip has reached the the neck with ease, with no tension and no shortening. We have a very long stomach conduit, and we were happy about the length reaching the neck with no tension. The tip, as you can see, is showing in the neck with the reinforced stapler. And now we'll do a side-to-side functional end-to-end esophagogastric anastomosis. Apply a couple of stay sutures on both sides. We'll do a gastrostomy and a esophagostomy. We'll just drain anything in the stomach to decompress it. Suction is going down the gastric lumen. And almost a 4 centimeter esophagogastric anastomosis will be applied by a stapler. The common enterotomy is closed with interrupted sutures. And of course, before that, I pull the NGT proximally and I deliver it down the gastric conduit to about 50 or 60 centimeter down there. Now the anastomosis is done. We're happy about our repair, and we just push back the anastomotic segment right in the normal position of the esophagus previously. And going back to laparoscopy, we put a drain in the left subphrenic area near the anastomosis. The patient did very well, stayed in 1 day in ICU, and pain was very controllable post-op. Gastrography done on day 5 showed no leak, and patient started orally on fluids. Thank you for watching.